Welcome to Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today we have the pleasure of speaking with Dr. Filomena Trindade. Dr. Trindade is a physician, teacher, author, and internationally recognized speaker who focuses on functional medicine and a holistic preventative approach to care. We're so happy to have you on the podcast today. Welcome.
Thank you.
Of course. So your session at the collaborative conference between A4M and CMHC deals with slowing the progression and even reversing diabetes. How do practitioners of both anti-aging and cardiometabolic medicine benefit from knowing about all of this?
Well, I think number one, just from knowing that it is possible, right, that the type 2 diabetes can be reversed.
Which is amazing.
But in many cases, they don't know how, or they haven't kept up with the literature. And so I'm really hoping to carry the message that number one, it's sort of this continuum, right? That before you develop the type 2 diabetes, you have pre-diabetes, you have impaired glucose tolerance. And that what we're seeing now is that you may even have insulin resistance and never progress, right? But yet suffer the same consequences. And we have way more pre-diabetics than we have diabetics in this country. But in general, traditional medicine has waited for someone to become type 2 diabetic before they intervene. And so my message is, let's intervene the sooner the better, because it's much easier to then reverse it and really focus on all the contributing factors. You know, why did someone develop insulin resistance?
Well, that makes sense. And you're the expert in the unique relationship between insulin resistance and hormones in women. Can you please give us a brief overview of how hormonal shifts in women's lifespans affect insulin sensitivity and how this can be addressed?
Wow, you know, it really can affect women at any stage of their life, right? We've seen more and more PCOS, polycystic ovarian syndrome, for instance. And we know that it's really about insulin resistance. And some women can be insulin resistant at the tissue level of certain tissues, but they may not be total body insulin resistant. But then menopause itself, or the perimenopause, brings that even more sort of to the forefront, because when you have these shifts, then it's going to affect insulin. And it's sort of a two-way street, because what I believe really happens, and I don't think we've done a really great job of explaining this or researching this, is that in the perimenopause, we always think, oh, your progesterone decreases, and then your estrogen decreases, and maybe your testosterone decreases first. But we really need to look at it in a case-by-case basis, because what I think starts to happen actually is that, number one, insulin I see as a major hormone and a major upstream hormone. That means that insulin has many effects on the other hormones. So I always think insulin first, then the HPA axis, thyroid, sex hormones, and then you have to look at how you eliminate your hormones. But my sort of biggest, I don't know, how would you call it, my biggest pet peeve probably is that with the lifestyle that we lead and the type of diets that sort of the average American eats more and more, it's all geared towards creating this hyperinsulinemic state, right? And so you go into perimenopause sometimes earlier, you develop insulin resistance in the perimenopause because you're having all these other shifts, but in general, you've become insulin resistant or impaired glucose tolerant, right? You've developed insulin resistance, but it was probably never really diagnosed. And then, you know, your cortisol goes up because, of course, it's the only cortisol. I mean, it's the only hormone that goes up with aging. And that is going to make your insulin resistance even worse. And you start to maybe decrease your progesterone and then eventually you lose your estrogen, or it may be happening close by depending on which patient you're talking about. So that we have all these different hormones that are going to affect insulin and insulin's ability to communicate and function. But in many cases, women are entering the perimenopause already in a hyperinsulinemic state, and they don't know it, right? And so it's really important. And there's many contributing factors. It can be changes in the gut microbiome, it's stress, it's the foods that they've been eating. And I know there's some exceptions, right? Because we have patients that eat healthier and sort of have that consciousness. But even then, it's extremely difficult in today's society, where I feel like it's geared towards creating this hyperinsulinemic pro-obesity state. So a lot of it is sort of having the foresight to begin with, but realizing that it's more about insulin than we originally thought. that women who develop your menopausal symptoms, where hot flashes, night sweats, it's usually due to the insulin. We always think about it's due to the estrogen progesterone. No, more often than not, because it's due to the insulin, because we have studies now showing that even after you've corrected or fixed or balanced someone's estrogen, testosterone, progesterone, then some women persist on having still the hot flashes, the night sweats. When you go back and you look at what the problem is, and then of course they're at higher risk for cardiovascular disease, it's all about the insulin that was never really looked at.
Geez, well, these are a bit of depressing factors, I'd say.
Fortunately, but if you have that as sort of it as your goal, and you look at insulin first, then it's not.
Okay.
Right? There's always sort of a solution.
Well, that's good news. So which comes first, obesity or insulin resistance? Data suggests that the two are closely linked, but does one cause the other, or is it more complicated than that?
Well, if you're going to simplify it, I'd say insulin resistance comes first. There are some patients that will develop insulin resistance because they're obese, but more often than not, it's the opposite. And I've looked at this for years now, and I'm constantly looking at the literature, and I believe that the insulin resistance came first. So there's a damage to the pancreatic beta cell. You start to have hyperinsulinemia, and we have different authors of research and researchers have talked about this, and really then what happens is that, and by the way, Barbara Corky is one of my favorite researchers on this area, so that you start to create a hyperinsulinemic state, and that hyperinsulinemic state then creates insulin resistance. Okay. And so then the question is, well, what did it? In many cases, it's damage to the pancreatic beta cell through different means, right? It could be a food sensitivity, it could be a toxin, it could be an infection. And then there's many different subtypes. It could be increased oxidative stress. It could be just stress in general. So it's really all about sort of damage to that pancreatic beta cell. But I believe it's the hyperinsulinemia first.
Okay. What are some questions providers need to be asking their patients with diabetes? Lab results and physical examination are so important, but what vital information can we learn only by asking the patient?
Well, I think you need to ask them about their history and what has brought them to sort of this far, where they are currently if you're doing an exam, and what was their childhood history? Were they vaginally born? Were they breastfed? Were they born by C-section? Because we know that's going to create changes in your gut microbiome. Mm-hmm. The other vital information that I think we need to be asking, and we don't always, is what different medications have they been on thus far? Because we know that medications can cause insulin resistance, right? We all know about the statins, but what about the PPIs, the proton pump inhibitors that are sort of thrown around almost like candy? Mm. So I think it's really important that we look at their history, what medications have they been on previously, but also their social history. Did they experience a lot of trauma? We know from the ACEs studies how important childhood trauma is. Mm-hmm. And sometimes it's not an easy subject to bring up right in the first visit, but I think it's important to mention it. And if patients aren't ready to talk, then we find the time later on when they are ready to talk. But there's so much information in terms of past trauma, especially early childhood trauma, mm-hmm. and its effects on our physiology, and particularly with respect to stress, and how we program our HPA axis, or hypothalamic pituitary adrenal axis, as well as what are their stressors and how do they relieve stress, because most patients don't have a way. Most patients don't know what to do to sort of decrease the effects of stress in your body. And sometimes you can't just remove the stress. Sometimes all you can do is buffer it, right? Is develop strategies that your body can deal with it a little bit better.
Well, that makes sense. So it's not all just about doing some yoga. It's more complicated than that, for sure.
Although that usually helps, but
yeah. What is the core of your Trindade certification program, and how does this education fill a gap in the existing medical training?
Oh, thank you for asking that. I created the Trindade certification program. It's all online, and it's going to be 5 different modules, but I haven't completed all 5. I have 2 that are running right now, and it's all about the first one's on hormones. and the second one is on gut, digestion, and assimilation. And so the first one, I created hormone ones first because it was the bulk of the patients that I was seeing. And I teach for IFM, I teach for A4M, and I saw that there was sort of a need for taking providers to that next level. So I saw and continue to see a lot of docs that come and do even the fellowship, or they do the modules at IFM, and then they're left with, how do I put this into clinical practice? What is that next step? When I did the fellowship way back when, I was in the first class, I was lucky enough to be in clinical practice already, and I was hungry for knowledge, and I just needed to help my patients, so I would start to implement everything I learned. Nowadays, I find that providers have a real sort of fear, right? They're afraid of being called by the medical board. They're afraid of changing. Even though they may have all the knowledge, they have a real fear of putting it into clinical practice. So I created this adult certification program to help those in particular. And you don't have to. I mean, this could be sort of where you start. But in general, it was more as a next step in how do you take all this information and then develop protocols to address our patients. So then the Soldado certification on hormones, for instance, I really talk about insulin being a major hormone, how it affects the downstream hormones, and then how do you address it? And I take sort of my colleagues and hold their hand in a way to try and teach them all this. How exactly do you do it? Because more and more, I think it's becoming a little bit more difficult to implement it and to know where to start and exactly, how do you do it step by step.
Wow, well, that's very interesting and very helpful for your patients. Thank you so much for all of your knowledge today. It's been a pleasure speaking with you.
It's my pleasure. Thank you for inviting me.
Of course. And don't forget to rate and subscribe and follow us, and leave us a 5-star review.